There we go. Let's make you the primary host here because this is you talking and I'm just here for the fun of it.
Hi, everyone. Hello. Oh, 1 second.
All good. Yep. Remember, this is the TikTok platform, so we play things a little bit calmer over here. It's a little more relaxed. It's just for fun, but also for a lot of education, and that's what we're here to do. So we have Kels, who is our official nonprofit researcher. Thank you guys for sending the gifts and the likes. Much appreciated. Much appreciated. And yep, she is back. Our wonderful, lovely presenter. We're happy to have you. And I'm going to let you roll from here. I'm just here to help moderate.
Sure. Hi, everyone. So, hi, Britt. Hi, everyone. It's good to see you guys. Oh, my goodness. There's 12 people here. So, I guess we'll introduce myself first on why I feel that I have any authority to even talk about any kind of cancer whatsoever. So, I have been in the research world since I was 16 years old, and I was working on the lab side of things, so actually processing samples and kind of on the number side, I always said, because patients at first are just a barcode. Everything is de-identified or completely just, you're not associated with anything that happens in research. It's completely private. So I started on that side of things. Once I went to university, I went to Emory University, where I got my bachelor's of science in biology as well as French literature. So for those of you wondering why I speak French, that is why. And from there, when I was simultaneously in class, I hear but not eating dinner. That's okay. What are you having? Sorry. So when I was in undergrad, I started in geriatric memory care, specific types of research around Alzheimer's, dementia, Parkinson's, motor degenerative diseases, things like that. Once I graduated, I went to the bedside. So I was patient-facing in emergency medicine. I did that for 1.5 years in pediatrics, and that's where I transitioned back to research full-time. And I started still in pediatrics there. So basically, I did very, very elderly patients, then very tiny humans. If you hear my dog, ignore him. And then I moved from pediatric endocrinology and diabetes care to research in oncology. So I did that for 12 years. And my sphere was this. It was GU, or genitourinary. That means any organ of the body that has anything to do with urine is what I dealt with. So that had everything from the adrenal glands, the kidneys, the prostate, the bladder, the penis, the testicles, all of those guys is what I did. Oh, thank you. All of the proceeds, by the way, to this will go to the organization itself in order to further kind of expand knowledge surrounding both clinical research and also clinical research in the oncology or cancer space. This is an open platform, so you don't have to ask a question about bladder cancer specifically if you don't want to. If you have a burning question about what the heck does research look like in cancer, please ask. I did have a few DMs that came in, and I have those written here. That's why I went to go get the notebook. So awesome. I've had DMs from this week, and I wanted to start addressing those, and I do see a couple of those individuals here already, so welcome. I always assume that if you DM me the question instead of asking it here in the chat, that it's because you wish to remain anonymous. So if you don't, then say hi, but otherwise I will treat it that way. So the first question that I had was, how can you do research on cancer patients if that means giving them a placebo? Fantastic question. So I'm going to first preface this by saying placebos, what they are. So the word placebo comes from ancient Greek, and it means basically to make you believe is the best way to translate that. And so it's something that is given but won't actually, hey, Katya. Hi, Big Girl Kim, hi.
Hi,
and so
everybody. Thank you for being here.
It won't actually do anything, right? So the idea of this placebo effect is that there are some patients, which is that mind over matter discussion, that even if they're given a little sugar cube and they're told that that's medicine, that in some way, shape, or form, they're going to feel better to a certain degree. But that doesn't mean I'm treating anything. I wish cancer worked that way, that it would be mind over matter. But now that we have a way of what the definition of a placebo is, the next part is there is never a placebo in a cancer trial. To say it one more time, we will never use a placebo on a cancer trial. What we will have are called controls. So what is a control? A control is someone that's not treated with the thing that we're trying to figure out. For the context. In bladder cancer. Oh, thank you, girl who rolls. Thank you.
Thank you, Alicia.
So for bladder cancer, we have a particular medication, good evening. This medication, we call it, for the sake of this, I'll call it EV. EV stands for enfortumab vedotin. We're never going to call it that again. That's really long. EV, like electric vehicle, EV. So EV, when it was first being tested as, hey, does this possibly work on patients that have bladder cancer or urothelial carcinomas? The control group was the group that we were treating with what we already had, which is chemotherapy, typical chemo. So anytime, what are chemotherapies? These are very general medications. They affect your entire body, which is why they, A, work really well, but B, have all of those classic kind of syndromes that we know and side effects that we're known to, the hair falling out, the vomiting, the nausea, all of that. So that control group of, okay, we know what's going to happen with these patients. We know that chemo works. That group is still getting treated. Now the other group is getting treated with the same chemo, and then we're adding the extra, right? Because in research, that's the whole thing. We don't know if that thing is going to work. It might be the next best thing, which in the case of EV, it was. But that would be completely unethical for me to be like, hey, this could or could not work, but I really need to find out. I still have to treat your cancer. So both groups of patients are going to get the same medication. There's just one group that's going to get a little something extra. Now, that something extra could boost them, and suddenly we have these patients who have their cancer shrinking by 30%, and the other group, their cancer shrank by 50%. Amazing. So we have what we call symbiosis. We got a relationship working here with the cancer, getting treated with these two medications. It could be the opposite. We could have that control group getting the chemo, reducing by 30%, and that other testing group where we combined it, not only is it still 30%, so we didn't do any better, but now we have a bunch of patients that have all kinds of new side effects that we weren't seeing. We don't want that either. So that is how we will work in research in the cancer setting. We will never, ever, ever use a placebo. Again, it's just not ethical. I have to treat you. You came to me because you needed help. But the question more is, are you getting something extra, or are you just getting what you would normally get? So, of course, sometimes the patients, they get discouraged because they want the fancy research thingy. And it's people like me whose job it is to make sure, okay, hey, just because there's something extra in this B group, what we call, A and B, just because B group is getting something new and you got assigned group A, that doesn't mean your cancer is not going to get treated. Your cancer is getting treated with the best that we have already approved. B group is just getting something already approved plus what we're trying to figure out. I'm hoping that answered the question. If it did, let me know in the chat. And you can send me a direct... Yeah, you can do that too. That's really creepy, TikTok AI. And actually, let me hold on the screen real quick because I meant to share this out to Christy Lynn and a few others. So give me 1 second, but I really hope that answered your questions. There's a couple of people that I wanted to make sure we're aware. There we go. Okay, cool. So that was question 1. The next question is, if you have bladder cancer, do you also have kidney cancer? Fantastic question. So, and that one was actually by TK. So TK, if you're here, kisses and I love you.
Love TK.
There she is.
Yes, she is. Hi, TK.
Okay, so fantastic question. So for this, I really wish I had my dry erase board. I will bring it out of my room for next time. But I want you guys to envision your urinary tract system. So you got a kidney and a kidney. You got some tubes coming out of those, and then you have your bladder. So they're all connected. And then on top of your kidneys up here, you got 2 little bubbles, and those are your adrenal glands. So that's what your urinary tract looks like. Adrenal glands, kidneys, tubes into a bladder. So if you have bladder cancer, you do not have kidney cancer. But that does not mean that your bladder cancer cannot metastasize, which means start in one place and then go to another, into the kidneys. That also does not mean that just because your bladder doesn't look like it has cancer, but there's a blob inside of your kidney, that when I poke that blob to get a biopsy, that it may or may not come back as urothelial carcinoma. Now, very important with that distinction, we treat each of these separately. What does that mean? When you get a biopsy done, it's because you have some sort of growth somewhere that shouldn't be there, right? Or, oh, DMS, I'm glad. Please let me know also if I'm talking too fast, or if something that I say does not make any sense, or if I randomly switch into Spanish or something, please stop me. Or if you need me to say something in Spanish. What about the lungs? Also the lungs. I was about to get to that, exactly. Any biopsy anywhere in your body, it's really easy to immediately be like, oh my God, I'm getting a lung biopsy. I have lung cancer. Very easy to say that. The issue is you don't always know what part of your cancer journey you're entering. Sometimes you're joining in the middle of the race, so to speak. So, because Shanice, as you brought up the lungs, I never smoke. Yes, that's actually a very common thing that can happen. We're seeing it, unfortunately, more and more, and it has to do with the filters inside of cigarettes. Our smokers are actually now there's what's called an intercept in the diagnosis, where we're seeing actual smokers get diagnosed more with bladder cancer, and the secondhand smokers, so the spouses of these individuals, the children of these individuals that never smoked a day in their life, or maybe people that had risk factors from their job. I'm looking at all my military boys and girls, and they them. But in those groups, they are the ones that are actually getting more lung cancer incidents because they're unfortunately breathing in the same chemicals without that filter that's inside of the cigarette to protect them. So the actual smoker has a filter that's protecting their lungs, but that's not protecting the inside of their mouth. How many smokers can get lung cancer per year? That is a fantastic. Let me get to my handy dandy. I have here something that's called a lexicon, which is kind of like a medication 101, like super fast. Let me type real quick. And so that's what I'm going to type into real quick. I will give you that number.
Thank you, everyone, also for being here while she is typing that up. We appreciate all of those love taps on the screen. That was just going to get more people in here that want to learn about Cancer Live, and we appreciate that, every one of you, for showing up. Thank you.
Thank you for that, Carissa. So the number is horrendous. I can't really call it more. And I do want to say that these numbers are not updated. We would have had an update of this in October, but because of the current government shutdown, the CDC and the NIH have not been able to publicize their most recent numbers. But smokers account for about 85% of the diagnoses of lung cancer in the United States. I'm only talking about the United States here. In countries like Spain, where it's very popular to socially smoke, it's much worse. But of that, that looks like, and again, I am citing specifically the CDC here, that is anywhere between 20 and 40,000 patients a year of a new diagnosis at any point in their journey. So that's from stage 1 all the way to stage 4. But again, that's only the ones that were smokers. If we look at the larger numbers, we are seeing these patients that unfortunately had exposure risk. They were breathing in secondhand smoke. There was even something that recently was studied called third-hand smoke. And so what is third hand? We have first hand. I am the person holding the cigarette, putting it in my mouth and inhaling. Now, what is second hand? Second hand is when I exhale all of what was in that cigarette, the person that breathes that in, that is the second hand. But what's third hand? If you've ever walked past someone and been like, whoo, they smoked today because it's in their clothes and their hair and on their skin and coming out of their pores, that is third hand. And believe it or not, that also carries exposure risk, we have found, because of the very heavy kind of soot that comes in the smoke that is exhaled. And so the person that smokes is in a way protecting their own lungs because the filters inside these cigarettes has gotten better. And I'm talking about cigarettes here, not cigars or pipe or, chewing tobacco either. But it does not protect the inside layer of the mouth. Because of that, that will enter the bloodstream, and that's where we see this affecting the bladder more often. And unfortunately, at that point, because everyone has lungs and everyone has bladders and everyone has kidneys, that's where we see these patterns. It's almost the incidence rate, as we say it, is proportional to the population. If more men smoke this year, then more men are going to get this lung cancer. But when it comes to incidence rate, it's equal on both sides. Women are not more protected. Men are not more protected from this cancer. So coming back to the idea of, well, if I'm getting a biopsy from my lung, I have lung cancer. Not necessarily. Believe it or not, any cancer can grow anywhere. And so when it comes to bladder cancer specifically, I like to call her something inappropriate that I'm not going to say online. So the most tangential thing that I can say is that bladder cancer is not picky. She can grow in the bladder. She can grow in those tubes, the ureters, the urethra, so the tube from the bladder outside. So when you go to actually urinate, the tube that takes the urine from the bladder into the toilet for you, that tube, all of the prostate, all of these places that are technically connected can develop what we call your primary tumor. that when you go to the doctor, you say, hey, I went to the bathroom and I looked in the toilet before I flushed and there was blood down there. Christy Lynn! And, that's something that you're going to come to me and you're going to be like, I don't know what happened. I looked down and it was red. What's wrong with me? We're going to do a scan. And let's say I'm talking about a man. I'm going to say, hey, there seems to be a mass on your prostate. We're going to go ahead and I'm going to schedule you with urology. Hi, Allie Kate.
Thank you, everyone, for joining. We love you.
And, we're concerned about this mass on your prostate. We're going to send you over to urology. They're going to do something called a biopsy. They're going to kind of poke. And this one I can draw. So, when you are a man, you have a prostate. And they are kind of round like that. And we do something that's called quartering, which means we draw 4 lines, like so. And each quadrant is given a name. So I'm going to try to invert it for you guys. So that if this is my lens, it'll be your right. So right upper, mid upper, left upper, right mid, middle mid. 1 second, guys. Oh my God, I'm so excited. I get to teach.
We love this. We're all here for it, as you see.
Lower and lower. All right. So we will divide with 4 lines. So quartering the prostate. And we will take biopsies from each little segment. So it becomes 9 segments. So we have right upper, mid upper, left upper, right mid, middle mid, left mid, right lower, mid lower, and left lower. So each one of these we're going to poke, right? So once you do that, the pathologist will look at each one. And when I say poke, I don't mean poke with a needle. I mean poke with a hollow point kind of tube. So it looks like a needle, but it's blunt on the end. Because what we're going to do is called a core. Hey, Rach. We're going to core this out because I want to actually collect tissue inside of that tube that I'm using and I'm coming out and I'm getting a little bit of tissue from you. We will look at that tissue. They're usually about this long each. And the pathologist's job is literally to look at each segment and be like, hey, there was no cancer here. There was no cancer here. There was no cancer here. Good, right? But here we had 20% cancer. Here we had 50% cancer. Here we had nothing. You see what I'm doing, right? We can suddenly map out. Here you had 100% cancer. 100% cancer. 0, right? So now I can tell you, hey, there is cancer just in this segment of your prostate right here. And I know what you're thinking. Well, yeah, the patient, if something comes back positive, they have prostate cancer. Not true. Once the pathologist does this, I know, Ripley, cancer is horrible. I swear to God, he's the most dramatic dog. Once the pathologist does that, what percentage of cancer is in this? And this is something that we do with anything that is a glandular. So if we did this with your prostate, if we did this with your thyroid, if we did this with your adrenal glands, this is what it looks like. With glands, you have to be really, really special. So after they do this, this is where they now do what's called histological screening. So first we said, did we even find cancer? Or did we accidentally poke your prostate a bunch of times for no reason? But the next thing we're going to say is, okay, but what did we find? So now is when you get all of the pretty stuff. The histologist, usually still a pathologist that has specialized. Now they'll do a bunch of different staining. So if you think back to when you were in biology and then you guys used to do that blue dye, that methylene blue that you would put on, and then you put it on the Bunsen burner and steam it. And if you didn't study biology and you have no idea what I'm talking about,
yeah, it's so fun.
No idea what I'm talking about. There are, and I have this whole kit. I didn't even think this through. I should have brought it. But you can dye all of these things different colors. So even bacteria, this is how we identify different bacteria, is the types of dyes that will stain them. Using those dyes is how we will find the mutations and therefore the type that they are. My mom had a rare bone cancer before she passed. Oh God, osteosarcomas are horrible. I'm so sorry, Shanice. Those are really brutal. For those of you that don't know, bone cancers, anything that says sarcoma in the name, are incredibly, incredibly rare. And because of that, unfortunately, my job gets hard because if it's rare, that means there's not a lot of patients to study with. So I appreciate every single one that joins research, and I'm so sorry. I'm so sorry, Shanice. It's brutal. Because again, they're unfortunately very painful cancers because they affect your bones, and your bones have so many different nerves kind of going through them. I just graduated in May with a bachelor's in bio, so hey, that's what I'm talking about. That's my ministry. So once they do that staining, they can actually say like, hey, so what happened was, thank you for the prostate tissue. None of that was prostate cancer. That was a crap ton of urothelial bladder cancer. And it has different names. They call it bladder cancer, urothelial carcinoma, transitional cell, all of these different names, just depending on how old the pathologist is, they will call it these things. And so I've heard so many kinds of cancers. There's so many, which is both terrifying, but also really good because it means that us researchers have done our job, because the more hyper-specific we can be, Missy, how are you? The more specific we can be with the exact type of cancer someone has, the more specific I can tailor your medicine. We have advanced enough now in cancer research where you don't go to the doctor and just be like, okay, you get chemo and you get chemo. Everybody gets chemo. We don't do that anymore. We still use chemo, of course. It's great at its job. But I have so many more options now. There's chemotherapy, there's immunotherapy, there's radiation therapy, there's cell therapy, there is proton therapy. We have a million different ways. We have TKI therapy, targeted therapy. We have a bunch of different ways that we can target these things so that you're as little affected as possible. My cousin had bone cancer in her upper arm and now she has a cadaver bone. Yes, we use cadaver bones as well. And believe it or not, they actually take a lot better than organs do. So when someone receives an organ transplant, first of all, they're on immunosuppressants the rest of their lives, so they take steroids forever and ever and ever. But there's kind of an expiration date on the organ because it won't grow with you and it won't age with you. And it also won't age the way that you do. And so this happens, we see this a lot with our pediatric patients, our kids. They'll get maybe a heart transplant when they were 5. Well, when they hit a growth spurt, that itty-bitty heart was not growing with them. They're going to need another heart transplant. It's very, very stressful. You can imagine parents, thank you, no job in sight yet. Rach, remind me where you live because we need good researchers. Pretty please, although I will say there is a hiring freeze kind of across the research board, and that has to do with the freezes on our funding. But gotcha. So you can have what we call like an originating tumor in an organ where it was not born. You can have bladder cancer where you actually first detected in the prostate or in the kidneys, but it will be that pathologist. It will be our biopsy that will have the final say of, hey, that tumor that you saw in that one place, it really did come from there. Currently in Alabama, but I'll go anywhere. Well, in that case, Alabama not ain't too far from Atlanta, I'm just saying. We'll talk later. So, I don't even remember the original question. If I have a tumor in my kidney, does that mean I also have kidney cancer? So no, it does not necessarily mean that. Can you have multiple cancers at the same time? Yes. But I always want to really emphasize that, that the difference between the diagnosis and the originating tumor, hi Bree, will be exactly that. That biopsy is what's going to tell me that you have bladder cancer in your kidney, or you have kidney cancer that has metastasized somewhere else, that has gone somewhere else. So I'm hoping that answered you guys. Let me go to the next question. Okay, next question is, why is there, watching you on my computer, I didn't know you can watch TikTok on a computer, that's really cool. Why is there not, oh, you're not late, you stop that.
Just join in anytime. We're happy to have you.
And please drop your question. Just because I'm talking about these questions that were DM'd to me does not mean I won't take them from the chat too. That's actually what I have Carissa here doing for me. So please, if you have any questions, I kind of just pop into your head. Oh, yep. This is a 2-part question because of TikTok's word limit, but 2 persons with the same type of cancer. Okay. We have two humans. Okay. We're going to say Kevin and Casey. So a man and woman. Is it possible for one? Yes. Fantastic question. Yes. What causes ovarian cancer? We will go there next. So, can 2 human beings with the exact same cancer type, can one of them do really well on a treatment and then the other one do horribly? Absolutely. And that has to do, unfortunately, with our own genetics. The same way that I am Kelsey and that is Shanice, that exact reason is why I might respond fantastically to an immunotherapy, and Shanice won't respond to immunotherapy at all, but she does fantastic on chemotherapy. Our genetic makeup is just as unique as the genetic makeup of your own tumor. I tell every single one of my patients when they get a biopsy, do you want to keep your biopsy? I know that sounds really weird, but it's a piece of you. You made her. It's not nice that you made her. We don't like that you made her, but it is yours. And so I ask my patients all the time, the same way like when you have teeth pulled, the dentist is like, you want to keep your tooth? It's the same idea. Do you want to keep, in like a jar, the thing that you're battling? And one of the reasons that we do this, because we have to, again, with these biopsies, we do take a decent chunk. I mean, I'm not like putting a hole inside you, but it's enough for me to study. And because of that, that's what lets us do, remember when I mentioned that staining, what is cancer like in a person that is immunocompromised? I will get to that next. That's a little bit more involved. I'll get into that one next. But when you're looking at that staining that I mentioned before, part of that staining also tells me what kind of mutations does your specific cancer have? And that can tell me what's actionable. What about your cancer makes it weak? I want to take advantage of that. Pretty please. And so with that, I'm going to mention just one mutation in particular. We call them PD-1s, protein designated ligands, PDL-1s and PD-1s. They're both in the same family. And so the idea with these is that if your tumor, your tumor in your bladder cancer is expressing those PD-L1 markers, then I'm going to assault them. The problem is your bladder cancer has them. Mine might not. And so if yours does, you're going to respond to pembrolizumab or any of those MAB, any of those monoclonal autoantibody immunotherapies. I like that you can see your face. But the next person might not have any of those PD-L1s. Or maybe they do. But there's a secondary mutation that they have that makes it irrelevant that they have it. So all of those are the little things that, I mean, our department, I always used to say we flirt with the pathology department because I can't do my job if I have a bad pathologist. I need every single mutation you found. I need every single designation. So every single type of bladder cancer that you see in there. Is it transitional cell? Is it small cell? Is it, what other types do we have? Is it papillary? I want to know everything you can tell me about this tumor so that I can be as specific as possible when I treat it. So that would be the main reason why one person will respond and the next one will not. And that's also why our job is so important. I can't just do like, okay, EV and that immunotherapy over there called pembrolizumab, those work for bladder cancer, move on. I can't. I need 17 options. Because a person that responds today to those drugs might not respond tomorrow. And a person that didn't start responding from the beginning, well, they need something. So that's why our job is, that's why I always say like the journey is never over. Because especially if you think about it at diagnosis, you know, if you're a 28-year-old getting diagnosed with something like this, you're going to be fighting a lot longer than someone who's 80, which also means your tumor has longer to mutate and fight back. So I always need to be 2 steps ahead. If I only have 5 treatment options, the 80-year-old is probably going to get to a point where their cancer is under control and they're okay until the day that, you know, they pass away in their sleep. But the 28-year-old, by the time he's 40, I'm going to be like, sorry, I only had 5 options and I can't help you anymore. And that's just not fair. Now I have a 40-year-old husband of 2 children who can't be there to see his kids go to college. That's not cool. So our job is never, ever, ever over. I hope that answered for you. And oh my God, what did I do?
I don't know.
You said it was on my end.
We did have a question about what causes ovarian cancer.
Ovarian cancer, yes. I was just scrolling. Perfect. It won't let me tab always open.
And just trying to help. I don't know what's going on.
Oh my God.
I love that.
I didn't mean to send you tabbing. So what causes ovarian cancer? That is a little bit loaded. So I'll break it down into 3 groups. There are those that are genetic. It was in your family. There's a group of mutations, and a lot of you may recognize them, but there's a group of mutations that we know will cause this class of cancers in women, and they're called the BRCA mutations. So BRCAs. There's BRCA1 and BRCA2. If you, unfortunately, were just born with those mutations, you are already predisposed to not only ovarian, unfortunately, ovarian, fallopian, uterine, cervical, vaginal, and in some cases even anal cancers. It is, and also breast. I don't know if I mentioned breast. And so these are conversations that women are having with their doctors where there's deciding, take it all off of me. Just, I will get, I will get a breast augmentation later. I will repair this, but cut it all off and cut it out of me. I don't want this. It is, it used to be really frowned upon almost, right? It's just like, oh my God, you're like destroying your body. I'm not destroying it any more than the cancer will. And so now it is actually the first thing that is done with any woman that has any of these cancers in their history. It is the first thing that most OBGYNs or obstetric gynecologists will recommend. Say, hey, we're going to do this genetic testing. If any of this is positive, we need to have this conversation. How do you want to proceed? Some women will wait until they've had 1 or 2 kids, and then they'll say, okay, you can take it off now. And especially if you're having a cesarean, that's actually a very popular option, is after they've had their child, they'll say, since you're cutting me open anyway, just take it. The other options, of course, is to wait and see. It's not a guarantee that these mutations will cause these cancers. It just drastically increases the probability, right? So that's group 1. Group 2 is what we call incidental. For me, this is the worst one because it's just random. There's no way to know what has caused this. There's no way for us to have like seen this coming. A lot of patients will be like, is it because I smoked weed that one time in no way to know. There's no way to know. You had no risk factors. You were not someone that ate super unhealthy. But you also you weren't the healthiest, but you also it's not like you ate Doritos breakfast, lunch, and dinner. There's just nothing about you. This was just life. So that's the one that I always hated because I would have the patients like, what did I do? Nothing. But you got to meet me. You can tell the kind of clinical coordinator that I am. So the third group is the risk factor group. So this is, for example, I see ovarian cancer a lot with any of my women that are service members that have served in the military because as pilots, for example, there is no protection from UV, so ultraviolet radiation, from underneath the plane. So just like my male pilots have an obnoxious amount of diagnoses in the testicular cancer and penile cancer rates because of this, for women, we see a lot of both vaginal, cervical, and ovarian cancer diagnoses because there's just nothing protecting them and all that radiation is coming straight up through the cockpit. So that's just work risk associated. Any woman that also has, again, not incidental, risk factor can also have to do with anything about you that is not necessarily, they don't necessarily hold hands, but they kind of have to do with one another. I fall into this group. So I have polycystic ovarian syndrome. So I have a lot of extra polyps that grow. And what is cancer? It's extra bubbles that grow. So anytime you have what we call neoplasm, so new plasm growth. New growths that, they shouldn't be there. Think of it this way. Every cell that is growing, my hair is doing obnoxious things. Don't get curly hair, you guys. Anytime you have growths of any kind, think of each cell as a chance that there could be a kink, that there could be a mutation. So if you have let's say, I'm going to make up these numbers, but just for the sake of the analogy, let's say a healthy ovary has 100 cells. So that's 100 chances for each cell for one of them to have some sort of genetic issue, some sort of mutation that results in a tumor.
Thank you, Chrissy Lynn.
What happens with someone like me? I have 1,000 cells in there, not 100. I have tenfold because I have all these extra polyps. I have all these extra bubbles in there that shouldn't be there. So where the average woman has 100 chances to get ovarian cancer, I have 1,000. Right? So these are what we call just the associated risk factors of just, you have polycystic ovarian, and I am so sorry. You already have all this on your plate, and don't forget about dessert. So those are the 3 main classes for the causes of ovarian cancer. And we could go further into like pesticides and exposure contact, but those are really the 3 big ones that we talk about. Can I go good, Shanice? I'm going to scroll.
That's good. We did have a question about, or from Mary commenting like, oh, that makes sense why there will never be one singular cure.
Yeah. And it just sucks because, it's like we come up with something that's so good. I go back to this EV, this enfortumab vedotin. medication. It was what we call a breakthrough medication. So you guys know that there's all kinds of requirements for the FDA to approve anything. People complain. They're like, God, it takes 20 years to make a new medication. And that's why, right? The FDA is like, I get that it works, but like you killed 12 people to get here. That's not a good thing, right? They're trying to protect us. But when something's really, really effective, they will grant what's called breakthrough approval, where it's like, I don't care what the data looks like. That's freaking fantastic. Go, run with it. We can talk numbers while you guys are giving this to the people. The people need this. EV was that drug. 2019 was a huge year. I mean, the way we threw a party, because it's really hard to get that. But it was the first time we could go to a bladder patient who was otherwise getting a death sentence and tell them, hi, there's this really cool drug. Couple side effects I want you to know about. It causes neuropathy, so it can destroy the nerves on your fingertips, make them numb. And really weird, it can make your eyes water really annoyingly. But it might fix your bladder cancer. So I want you to sit down in that chair. I'm going to give you this med. So it was amazing. Before we were just like, hi, so we're going to try to give you some chemo and then we're going to pray. And it's currently July. You may or may not make it to Christmas. It completely changed the conversation we were having. What is cancer like in a person that is immunocompromised? So I'm going to talk about this in twofold, because there's patients that come to me already immunocompromised, and then there's the patients that I made immunocompromised. So I'm going to start with the first group. Patients that are already immunocompromised. So for example, they have lupus. I don't care. Truly, like just to be as generic, I don't care. It changes how I can treat them. Immunotherapies, for example, would not be my first choice because I already have a patient whose immune system is kind of doing weird things. I don't need to make it do weirder things. These are the patients that I would make laugh. I'm like, listen, if I give you an immunotherapy, you're going to sprout a third arm out of the back of your head and you're not going to know what to do with it. I'm not going to know what to do with it, and I don't want to write the essay about it. So we're just going to go to a different class of medications. But again, this is the work of us researchers. I need to think about every single type of person because every single person can get cancer. So a person that is already immunocompromised, again, in the example, they have lupus. It just means that instead of treating them with A, B, and C, I treat them with D, E, and Z. That's all. Now, for a person that I made immunocompromised, you came to me, totally yourself, totally normal. You're like, yo, they told me there was something stupid inside my bladder, and now I'm here. I said, cool. I'm going to give you this, this, and this. I know, Ripley's horrible. So the most typical thing is, let's say I have a 55-year-old man, otherwise healthy. You're actually thinking of a particular patient. He runs marathons. He's vegan. Stupid healthy. You shouldn't be here, but now we're friends. I'm going to treat you first with chemo. Like I said, chemo is still a great option. It just has a lot of side effects. But if you are strong enough, you're able-bodied, I'm going to treat you there first. Chemo does a great way of just kind of stopping everything in its tracks. It won't necessarily shrink your tumors, though it can, but it won't do that as well as it just stops everything from growing. Like everything just kind of pauses. So I'll treat you first with chemo. And then the next plan would be to give that EV medication. That's called a conjugate, by the way. We'll give that conjugate medication with an immunotherapy as well. Those kind of, they're boyfriend, girlfriend. They go all together. And I will treat you with those as long as I can. But what happens? One day you call me and you're like, hey, Kelsey, I really don't feel good. I say, what's wrong? I don't know. I woke up this morning. I had a 102 fever. I say, come into clinic. We can provoke what's called neutropenic fever. This is a specific fever that's not because you're sick. It's not that you have the flu. It's that you have so little white cells because I have immunocompromised you. The treatments I gave you just shocked your bone marrow to such an extent that your body's like, I don't know what you're doing to me. I am so tired. What the hell is going on? And everything stops. Not just the cancer, everything stops. And so even your bone marrow is not kind of in shock. You're not making white cells. So you come to me, I draw some blood, and I see, holy crap, you don't have an immune system. You don't have these neutrophils. These are the first line of defense for your white cells. I have to stop everything. I cannot continue to treat you for as long as you are immunocompromised. Why? Well, it has nothing to do with your cancer. It means right now you are so hyper vulnerable to anything else that I might kill you. And it's not the cancer that's going to kill you, it's me. Case in point, a bit of a tangent, patients that are diagnosed with HIV The reason it's so imperative to keep their HIV under control is because I never want them to cross that line into AIDS or acquired immunodeficiency syndrome. Once they get there, they have no immune system whatsoever. It's not the AIDS that would end their life. It was, they would get the cold. They would just get rhinovirus. They would just get a stomach bug. And because they were so weakened, they couldn't fight it. And it was something that we would otherwise say, it's like, how did a 30-year-old die of this? Because their immune system was gone. It's the same thing with these cancer patients. I can give you something that knocks your immune system so far down, you can't even fight the flu. And I can't have that, right? If my treatment of your cancer is like, the good news is I killed your cancer. The bad news is you're not in the ICU. I didn't do my job, right? We have that conversation with our patients all the time. Realistically, how do you want your journey to look? And you're like, listen, I've got 6 grandkids. I just want to be able to like go to their soccer games. And the oldest one is 15. I want to go to her quince in a month. Like, that's what my job is. So if I have a treatment that I know is going to work, but it's going to hurt you like that, I'm not giving it to you. So I hope that answered that. I know that was a little bit longer than I wanted it to be, but I tried my best. I'm scrolling.
Is there a way to develop treatment without the major side effects, such as neuropathy?
So, yes, with an asterisk, but yes. So I think you're talking about targeted therapies. So, how do I say this? So there's always going to be something. I don't know of a single medication that doesn't have some sort of side effect. The question is the side effect something long-term? Is it something that comes from exacerbated use? So for example, like I think about Tylenol, for example. Tylenol is pretty much harmless. Like you can even take it when you're pregnant. It does not cause autism. It is one of the safest medications we've ever created. It is fantastic for dealing with pain, for dealing with fevers. It's an antipyretic as well. And yet, if you take too much of it, I believe the limit is about 5,000 milligrams a day. So that's also a lot, right? But were you to pass those levels repeatedly, you could go into kidney failure. So there's truly not a single medication, and that goes for holistic things as well. For example, I think a really popular extract that is used a lot that I hear is elderberry. Too much elderberry will cause cirrhosis or liver damage, irreparable liver damage. So everything in excess is going to be a problem. However, to go specifically here, is there a way to develop a treatment without a major side effect? So something that is permanent and irreversible, that is where we're trying to do this tailored medicine. So the big 3 for this one is going to be targeted therapies. I'm going to talk about that one first. Cell therapy and proton therapy. So each one of these groups is a more specific version of something that already existed. So targeted therapy is a more specific form of chemotherapy. Chemotherapy, very general. If it grows, I'm going to kill it. The problem with that is your stomach lining grows, so it's attacking that, hence the nausea, the vomiting, the diarrhea. Your hair grows, hence the hair falling out. So it's very general. Targeted therapy, I'm going to attack anything that specifically has a TKI mutation. Only cancer has this kind of mutations. So much more honed in. But now the problem becomes, well, fantastic, it's targeted, but this person has liver cancer. And liver cancer is very, very prickly. Liver cancer does not like anything to do with her. That's why I always tell people, if you drink, make sure for every drink that you have some water. Because once your liver starts getting abused, she's dramatic. Your enzymes start going crazy. Your skin starts turning yellow. You get jaundice. She's not too. I always like to call this, it's your mom. Your liver's your mom. She can handle your bullshit until a certain point. But once you get right there, silent treatment for 5 days. She's not talking to you. When she does talk to you, she's really snippy. That's your liver too. So there's always going to be a kind of give and take with all of these. But that's the first one. The second one is cell therapy. So cell therapy is the new and improved version of immunotherapy, where I specifically go into your body, I pull out cells, and I engineer them into little warriors. And I'm like, hi, You have a mission should you choose to accept it. Find her. Kill her. Which is fantastic. And it'll do it. It does so good. Oh my god, it's so freaking cool. But when I first engineered your little warriors to attack this thing, you only had the tumor in your bladder, your lung, and in your thigh bone, in your femur. What if I start treating you and you got all your little warriors and it went to your brain? Now it's more complicated, right? Now we're talking about a really tender spot. I don't necessarily want soldiers with, charge! No, I'm not in the brain, right? So that's where there's some risk there, because now I have to jeopardize this, because we've got 3 major areas where you have cancer that I gotta tackle. So I have to, pros and cons. I gotta be like, okay, I'm gonna run the risk that should this get away from us and go somewhere else, this is my job to inform my patient. If you start getting headaches that you never used to have before, if you start getting like weird blurry vision, I need you to come immediately, because that's telling me, hey, those warriors, I told them to go here, there, and there, and they're going in here for some reason, and I'm throwing you in an MRI. That third group, hypertrophy, which for anyone that is in Boston or in the kind of New Englandy area, love you guys, because this is y'all. So it started with Boston children. So we had children developing these brain tumors, these glioblastomas. We all know glioblastomas, right? John McCain had it. Joe Biden's son had one. Terrible, horrible. They're called butterfly tumors. They grow like this, but they grow sideways. They grow like this in your brain. I can't cut that out, right? These are inoperable. I would have to slice your brain in half, open it up, pull out the tumor, close your brain. I wish it worked that way. And so, no one deserves to die, and no one deserves to die like that. But I still remember when John McCain was diagnosed, and he said, you know what, I've lived a life. And he did. He lived a life. And you can feel how you did about his politics. I felt a certain way about his politics. But the way he took his diagnosis was with grace. And he was very humble about it. He's like, listen, I've lived a life. I'd rather it me than my daughter. I'm 78 years old. Screw it, right? But when someone like Biden's son, someone in their 30s or 40s, when you have a child, you have a 5-year-old being diagnosed with this thing. I mean, I have pressure, but it's like, there's pressure and then there's that, right? Like you're telling me the father of 2 with a wife, I'm telling him that no, we got to figure something out. And leave it to Boston Children's to talk to Harvard, and they were like, we got to do something. And we have an ungodly amount of money, right? Harvard has a fantastic, it's in the courts. But anyways, they have a fantastic endowment. We got to do something. We have the money. They developed radiation, right? We have radiation. We know radiation works in brain tumors, but it also scrambles your brain, so to speak. So we got to do something. What if we were able to make the radiation, instead of zapping your whole face and zapping your whole brain, what if we could laser point it? That's proton therapy. So instead of a whole beam of everything coming at you, for any of you that have seen radiation before, you know what I'm talking about. For those of you that haven't, when you are receiving radiation therapy, it's to a generalized area. If you have, let's say you have a lung tumor like my father did. My father's tumor was right around here. Which is kind of dangerous, right? Your heart's on your left side, so they have to really, really hone in and be like, we got to get as tight in here as possible because I don't want the radiation to mess with anybody else. But think about everything that it has to pass through to get to that tumor, right? Your skin, your muscle, your bone, and then the healthy lung tissue before it gets to the nasty tumor that's in there. If you like video games and you like science, you would love proton therapy. Consider the career, because that's literally what they do. They digitize your body, create it into a grid, and then they say, think of for those of you that played Monopoly with Battleship, they'd be like, okay, we have this little proton, this package of radiation, and now that we've mapped out patient zero's tumor in their lung, we're going to have it detonate at 2-4. And that's literally what we do in your body. We will literally map it out and be like, okay, I need this tumor to go in 17 inches, and at that point, I want it to explode right in the middle of that tumor. So the only thing affected is that tumor. It just explodes dead center in there. So those three. Here's the problem, though. Where is the tumor that we're talking about? Again, if that's on the liver, we're still going to have issues. Right? The liver just doesn't like messing with anybody. And that's my husband texting me. Why are we texting me?
Hi, Rob.
Hi, Rob. Oh, he's picking up my medicine and he's like, I hate traffic.
Well, bless him for doing that. Thank you also.
Yeah, I'll put my medicine away. Like, it took me too long to pick it up. Okay, so I hope that answered. I know that was really long, but those are the three main, like, kind of most advanced options that we have, and you still see side effects. Unfortunately, there's always going to be a side effect, because if you think about it, I'm fighting a part of your own body. And that's what sucks about cancer. It's your cancer. You made it. You didn't mean to, but you made it. And so it gets hard to fight these things without something happening. We have really learned to mitigate them. Again, proton therapy does fantastic mitigating these effects. Immunotherapy does as well. God, they're still there. They're still there.
So
the way they are with everything, but definitely more. What did I do? There it goes.
Tella asked, would this be why removal surgery is highly suggested over immunotherapy?
In some contexts, yes. For example, if you're still in stage 1, yeah, I don't want to touch you with anything other than I'm going to chop that out of your body, and I'll see you in 6 months for a scan. Absolutely. If we are dealing with a cancer that is still what we call encapsulated, I'm going to move away from bladder for a second, because we'll never talk about bladder cancer like that. But, well, we kind of will. But in one very specific scenario. So I'm going to talk about kidney instead. So the kidney sits inside of what we call a renal capsule. So it's literally inside of its own personal little sac. When we first do that biopsy that I mentioned, it's really, really important that we have a really pretty scan, preferably an MRI scan with and without contrast, because I need to see where exactly that tumor is sitting. If it is still completely, what we say, completely contained inside the renal sac, I'm not even doing a biopsy. Because if I poke it and therefore poke a hole in the sac, I might give it a window to then exit and metastasize and give me all kinds of problems. So at that point, I just be like, you know what? It's still contained in the renal capsule. So it's stage 1, 2, or sometimes even 3, depending on the size. But I'll be like, listen, this is stage 1. This is your urologist. He's going to operate. He's going to cut it out. I'm so sorry. You're about to have what we call a radical nephrectomy. We're going to take the whole kidney away from you. You've got a second one. Don't worry. But yes, that is why, if we can, our first option is always, we call surgery. And they have gotten so good. If you look at the history, specifically with breast cancer, if you look at the history of how we started with surgery in that realm and then have grown to where we are now, it is night and day. It used to be pure butchery, what we would do to patients, because we couldn't see. But the advancements in radiology and the imaging that we can do have been fantastic. And so we can really hone in and be like, I just need to do what we say, resect, so cut. And as long as we have what we call negative margins, so there's not a single iota of a cell in the entire boundary of what I cut out of you that has a single cancer cell, amazing. And they do so freaking good at it. We even have interventional radiology, which is where they're operating actively inside of a CT machine so they can see everything they're doing, like microscopically. I mean, there's patients that we'll see and we're like, we're never going to see you again. They did so good. Love you. Bye. And I love that. I saw one the other day at the supermarket here. He goes, yeah, I'm still cancer free. And I'm like, and I go, I love this. And he's like, but you'll be out of a job if it works so good. I'm like, that's fine. I don't need the job security if you're alive. That's fine. So yeah, it will always be the preference. We do offer in some situations, depending on how aggressive your cancer type was, like in bladder cancer, because they are so aggressive, where we'll still give a follow-up therapy. I'm trying to think. I think right now it's a atezolizumab. So we'll still do that resection. We'll remove your full bladder. We'll create a bladder using a flap of flesh called a neobladder. And then we'll give you some sort of immunotherapy just to act like a scout and clean out your blood of any circulating tumor cells that may be there. I don't need those landing anywhere they shouldn't. But outside of that, yeah, we won't really treat you. If it works, fantastic. I never want to see you again. Like, I'll meet you, I don't know, at the movies or something. I don't want to see you in clinic again. Oh, my husband just pulled it.
Yay, welcome home. So Mary asked, I know persons tend to sometimes relapse after being pronounced cancer-free. What causes that?
So I actually kind of just touched on that. So those circulating tumor cells are the problem.
Yep.
So I'm going to start from the very top and then go all the way down. So the most basic thing is they perform the surgery, they cut out what they thought was everything, and then we get a phone call from we said what very important when surgery oncology is operating and they send off the tumor, they don't close you immediately. They wait for the magic phone call. And so when pathology calls back and they say you do not have negative margins, everyone's holding their breath, right? Because now they're like, can I keep cutting safely? It's very important. You think to yourself, like, okay, just keep like scraping or something, like keep cleaning it out. You can't always do that. You might be close to a major blood vessel. You may be close to an organ like the liver. I don't always have that option. A really important one, for example, is with the radical nephrectomy. I don't like messing with your adrenal glands. They're also kind of annoying. They are very, very, I want to use a particular word, but this is being recorded. They are, I'm looking for it. I'm finding it. They're picky. Don't touch them. Leave them alone. Let them do their thing. So if I can do the nephrectomy, if I can do that kidney removal and leave both of your adrenal glands intact, I try to. If they just get angry and decide like, oh my God, he touched me, they just kill themselves. And they suddenly stop working. Which you'll think like, okay, like I have two. They are symbiotic. If one of them stops, the other one's like, oh my God, my friend. And they die too. And the issue with that is your adrenal glands produce a life-saving hormone called cortisol. You cannot survive without cortisol. So you'll immediately go into what we call adrenal insufficiency. If I don't get to you in time, you will pass away at home. Luckily, it's a very obvious syndrome. Like the patient has a bunch of things that happen and they'll usually collapse and pass out, which usually lands somebody in the ER anyway, and I will get to them. But it's very scary and it's very uncomfortable. You really don't feel good when you're in this kind of realm. So what happened now?
I want to know if you want to talk.
Sure. Does everyone want to meet my husband?
Yes.
Anyway.
Hi,
This
Rob.
is my husband. Hi. Oh my God.
Oh, presents for Kels.
Oh my God. What is it? Oh my God. It's a cat. That's really cute. It is Hello Kitty, y'all. I have such a collection of Squishmallows. We'll do a tour one day. So, stay, kitty cat. Stay right there. So, that's the first thing. If you're open on the table, I get that dreadful phone call from pathology of like, hey, thank you for the kidney, massive tumor. It was not negative margins. Something somewhere failed, and the tumor has grown outside of that capsule that we talked about. This is where, and a lot of times it's a resident operating on you. That's not a bad thing. They have to learn, and they're also very gifted. I always said by the time they go into their surgery residency, they're already very talented. So this is where, unfortunately, I've watched residents sob because they're like, I thought I got it all. It's like, it's not you. It's one cell sometimes. So this is where the attending will actually come in and be like, can I do anything? Sometimes, yeah, they'll scrape until we finally get the magic words from pathology. But also remember, I can't keep you under anesthesia for so long either. So this is where they'll say, like, you know what? It was already a risk to do this surgery. We got 98% of this. We're going to close this patient out. We're going to put them into recovery. Let medical oncology, that's what I mean. Let medical oncology take care of the microscopic stuff that's left behind, because I'm increasing the patient's risk the longer they're under anesthesia, and the longer that I'm just cutting and cutting and cutting, I might hit something else important. I may mess up a nerve somewhere. No. We're sealing up the patient. So that right there, that's a reason to relapse. You just didn't get it all. Another reason we relapse is we've learned that the way that we've thought about cancer is actually backwards. So the mentality has always been, you have a tumor, right? You had one cell that then grew into 2, that then was 4, and then was 8, and then was 16. That was just cancer and cancer and cancer and cancer and cancer, you get a tumor. And then one day the tumor gets another mutation and the cells start to pop off and start migrating elsewhere. It's actually the opposite. The first thing that ever happens is a tumor cell forms and it starts to immediately circulate in your blood. This can be from anywhere. A brain tumor. It could be from the kidney, the bladder, the anywhere. Melanoma in the skin, anywhere. Where it lands will then start to multiply 1 into 2 into 4 into 8 into 16 and become a tumor. So what's the reason that patients relapse is like, yeah, I finally found your tumor because you came to me saying there was blood in my urine this morning. I'm freaking out. The reality is that tumor hasn't necessarily been there for a while, but those tumor cells have been circulating in your blood for a while. And so they've just been circulating, not doing anything. They were just looking for the very most perfectest place to grow. But once they got there, then they started growing. And sometimes you have tumors. I'll go back to kidney cancer for this one. They're kind of gentle. If you could think of gentle and cancer in the same sentence, it doesn't really bother you until the day that you're like, oh my God, why am I peeing blood? And by that point, most of my patients are stage 3 and above. It doesn't really do anything. It's just kind of chilling in there, just growing. One day, like, oops, it got a little too big. And it pokes something and there's blood. Sometimes it's something like a lung tumor. Those guys show up a lot faster because you immediately get that cough, right? Something's like, doctor, I've been coughing for a month. What the hell is this? And now I do a scan. It's like, I can tell you what that is. So it really depends on the type of cancer we're talking about with that. But a lot of it has to do with, I think the paper won a Nobel Prize in biology. That was how big of a discovery this was. But I think it was in the last 15 years. So all of this time in oncology, and everyone on this call, like not TK, but almost everyone on this call has been alive long enough to have seen this shift in the way that we treat cancer. Yep. So that is it's kind of the stuff that we're up against. Is by the time you've manifested a tumor, you actually had cancer a lot longer than you think.
So we have another question, kind of backtracking a little bit about how does somebody live after a bladder removal? What happens and what does that surgery look like?
Sure.
As the family member of a survivor going through this.
Oh my goodness, who was that? Wait a minute.
Tella.
Oh, don't be sorry, Telly, please. So, 3 groups. Assuming that you came to me, this is assuming that the patient came to me, and they were not metastatic. They did not have bladder cancer anywhere else outside of their bladder or the immediate, tubing in the area. Okay, keeping that in mind. I treat the other ones. The metastasized patients, nothing I'm about to talk about is an option. If you already metastasized, I treat you completely differently. So keeping that in mind. 3 groups. Hi, I'm so sorry you have a bladder tumor. We performed something called a TURB, which is a very specific biopsy procedure called a transurethral resection of a bladder tumor, a TURBD. I really want to cut out your bladder. Option 1, go for it. I'm going to quote a patient. Cut that shit out of me right now. Okay. What does that surgery look like? There's 2 options. I can create a neobladder. That is where I create a flap of skin. I make it a bubble. And I put it there. When I remove your bladder, there's only 3 surgeons that are capable of this. I worked with one of them here at Emory. I leave the muscles in charge of, when you have the urge to go urinate, you have a sphincter, right? You have a little closure that you can release and then you pee. I keep the sphincter intact. So that's assuming that your tumor had not touched her. Otherwise, she has to go too, and this is no longer an option. But I leave the sphincter. I create the bubble. And I leave the nerves and the muscles in charge of compressing your bladder to allow you to urinate. And they will do the job for you. Fantastic. Second option. Hi, I want to cut out your bladder. Go for it. Fantastic. But I get in there and any of those are compromised. The muscles are compromised. Your sphincter is compromised. Anything like that. I can still make the neobladder. But you have to catheterize yourself. So for those of you that have ever seen a catheter, it's a tube that you insert. You pass what would be the sphincter. And immediately just all comes out. You don't have to do anything. It's annoying because you constantly have to be using this tube in there. And because it does not have the nerve endings anymore, you would never feel if you ever have a urinary tract infection or UTI. So it's a very elevated risk of developing these infections, and you won't find out about it until much later when you're running a fever and you're like, what's wrong with me? And you come into me, I'm like, you have a raging infection in that bladder because it's a sterile procedure to insert a bladder, and we don't always wash our hands as well as we should. Second option. Third option, hi, I really want to cut your bladder out. No, but you have a tumor inside. I really want to cut it out. No, you're not taking my bladder. That sounds insane. No, but I can make a neobladder and then no, you're not taking an organ from me. What the hell's wrong with you? Figure it out. That's the third option. Those are the patients that immediately get a referral to me in medical oncology. The surgery is like, hey, I tried. I really tried. The survival rates are completely different. It's about a 45% difference in survival if you let me cut out your bladder at first versus not doing so. But I'm going to be honest with you. If I was asked that question, I don't know what I would say. Knowing the numbers that I know, I don't know if I would agree to the neobladder surgery. It is an incredible life adjustment, especially as a woman. For men, it's much easier. You have the penis. You have a whole member. You just hold your penis and you insert the tube. It's a lot easier than us ladies who are having to find the correct hole. And remember, we have two openings. So the urethra, your little urinary hole, is much smaller than the vaginal opening. This is not the same as I had a patient. She's like, it's like putting in a tampon, right? No. Ours is much shorter. Men's urethra, think about it, from their prostate through their bladder, all the way out their penis. For us, it's about this big. So this is more painful, much, much higher risk of infection. I don't know if I would want that. And so for those patients, you have a permanent catheter that can be placed, and then you just always urinate into a bag. Again, there's still an infection risk with that, but it is less. But either way, regardless of your option, there's a lot of adjustment that has to be done. It's a lot of medical supplies. And again, think about how often you pee during a day. That's how many times you have to do this to yourself every single day. So how can family be supportive? This usually falls to a spouse, but I mean, there better be no secrets between you. I don't you guys really need to like each other, because there's going to come points where I'm going to talk about a patient that passed away, but I love this patient. He used to say, he goes, I hate peeing now because of this, right? He has to catheterize himself all the time. He goes, I really am glad that my wife likes my penis because she does it for me more than I do it for myself. I'm like, that's love. That's wow. And she goes, yeah, because otherwise he would just rather hold it, and you can't hold it either because that's going to piss off your kidneys, and now we have a whole other problem. So how can family be supportive is just take it as lightheartedly as possible. And also remember that cancer is a battle on multiple fronts. So wherever you can help, just listen, right? Because a lot of people, when they ask for help, it doesn't come in the form of, can you please do blah for me? A lot of the times the help, I can talk about this with my dad. The help was when my dad was at the doctor's office, and every time he was asking the doctor the same thing every time. When can I have my surgery? Right? He wanted the lung tumor to be cut out of him, but he needed 6 cycles of his chemo first. It was cycle 2, right? His second dose. And he was like, can I have the surgery yet? How was I supportive? Patience. I could hear the doctor getting angry with him, and I was always on the phone, and I would immediately perp up and go, hey, Dad, so we have to do 6 treatments, and you did 1, so we got 5 more. He's like, oh, okay. The next appointment. When can I have my surgery? By the time we got to, infusion 4, I was just like, hey, Dad, we're on number 4. We got 2 more to go. Sometimes that's what you have to do. It's kind of anticipate the needs. Because, the patient is not going to ask. Because they already feel needy as hell, right? They're like, I'm already the one with cancer. I can't be asking for anything else. You're driving me everywhere. I'm taking a crap ton of medicine. We can't go to Cancun on vacation anymore because, my treatment is once a week. They already feel so much guilt. I always tell patients, just try to anticipate so that you don't put the patient in that position of being like, hey, I know you guys want to go to Cancun, but I have treatment on the 2nd, and then on the 4th, I have radiation. I can't do it. Don't put the patient in that position if you can. Try to anticipate as much as you can. So that in the event, for example, there's a vacation, the person goes, hey, I have weekly treatment. You're like, hey, I already thought about it. you have treatment on Tuesday, so we're going to fly out Wednesday morning and we'll be back Monday night for your next treatment. You'll never hear thank you. Being a caregiver is, there's no thanks. You'll get thanks, but there's not a thank you that will ever suffice for what you are doing and what you are carrying. But none of us make it out of life alive, right? I think of my job as prolonging the inevitable. For some, I'm prolonging it for 50 years because you're only 20. For some, I'm prolonging it for 20 months because you're 74. But none of us are immortal. So I tell every caregiver, I want you to care for this person in the way that you can live with when they are no longer here, because I can't make them immortal. I hope that helps. We should probably do one of these where I just talk about caregiver fatigue, because that is a whole other conversation, and I can talk about that both from the medical side and also my side of things.
We would love. We can do that.
I hope that helped, Tele. I know. Please don't apologize for asking all these questions. Please.
Yes. Sorry. I hope we can help, Tele. Sending lots of love.
Cool. Yeah. And I have one more question that was DM'd, which is, why don't you like to say that patients are cured? I always hear in remission. That's a loaded question. I'm going to answer this one also in twofold. Yes, it does, man. I'm glad it does. My mother-in-law will be watching the recording too. Nice. So, why do we say in remission? So we, as a lot of people, we being the cancer community, will only use the word remission when we talk about liquid tumors. Kelsey, what is a liquid tumor? Leukemias, lymphomas, cancers of the blood specifically. We will say remission. And that has to do with the fact that it is literally something that you are actively creating as opposed to a tumor that is self-populating. So when we're talking about these leukemias, these lymphomas, these myelomas, these guys, that's what we'll talk about remission. And the magic number is 5. 5 years of me not having to treat your cancer, you have reached remission. You will always be in remission. The best analogy I can make for that is an alcoholic is always in recovery. It's an active verb. You have to keep living a certain way to maintain that status. So you are always in remission. I don't care if you had leukemia when you were 8 years old, you are still in remission at 47 for your leukemia. So with that in mind, what do we say for the solid tumors then? We will say negative for disease, or we will say no evidence of disease. NED is the magic. I guess I should type it this way. NED. Anyway, so how do we achieve this though? We achieve this because liquid tumors, I can tangentially actually calculate it, right? I can draw your blood sample and I can get a percentage. This percentage of your blood cells are cancerous. And the day that hits 0 and stays at 0, remission. Straightforward. Tumors that are solid are more annoying because I can't look at every single individual microscopic cell in your entire body. I have to look for masses. I have to look for activity. And even that is somewhat restrictive, but we can break down what we can do. When we talk about activity, hot spots, right? I'm going to give a little bit of a story here. There was a cat, for those of you cat ladies and cat guys out there. There was a cat. It was a stray. And I also love this story, by the way, because this cat recently passed away. But it was a stray. The cafeteria staff would feed this cat. It was very gentle, very sweet. And when they first met it, it had a collar, and they tried to find the owner, but they could tell this was a fully domesticated, always around humans kind of cat. And I'm like, it's harmless, whatever. Well, one day, they couldn't find the cat. They couldn't find the cat for a week, and they were like, gosh, shit, the pound got this cat, or the cat got hit by a car, God knows. No, the cat had wandered into the oncology ward. Why on God's green earth would a cat wander into an oncology ward? Well, cats have an innate sense, which has always made me laugh because we call it a CAT scan. A CT scan is a CAT scan. But they have an innate sense to detect heat, right? When they kind of loaf themselves and turn into a little bread loaf, it's because they're trying to contain the heat in their core. And so they're really good at finding heat sources. You know what else is really hot? Is tumors. So when I do a PET scan, PET scan, this is a nuclear medicine scan, I give you a special kind of contrast that will attach itself to hot spots, really active, hyper-growing spots in your body, like tumors. Now also, your eyeballs. So this is what I mean. Like, I got to be careful, because just because your eyeballs light up on a PET scan doesn't mean your eyeballs have cancer. I expect that. But I don't expect, for example, your stomach area to light up, especially if I already know that you have liver cancer. So what had happened? We lost track of this cat. No one knew where she was. Then one day a nurse goes into a room, and there's a patient, and she's petting the cat. The cat's on her belly, and she's like, what the hell? Brought a cat into the hospital? And the patient was just like, I don't mind. I fucking love cats. Look how cute she is, you know? And the nurse is kind of mortified. But she's like, ma'am, you can't have this cat. And she goes to take the cat, and the cat immediately just viscers and she's like, a rabid cat in here? And again, the patient was like, I'm not the problem, you're the problem. Get the hell away from this cat. And the doctor's like, I don't like this. And the nurse is like, I don't either. They're a freaking cat. He goes, it has nothing to do with that. I don't like that the cat is protective of her. And so now the nurse is like, oh, I don't know where this is going. And he's like, we need to throw her into an MRI. And when they did, this patient, who was in there for something completely different, a completely different cancer, had metastasized to her liver. The cat had detected it. The patient was about to get discharged home, being told that her surgery was a success, only to have a physical cat be like, nah, it's really hard and really hot right there. They kept the cat in that hospital until she passed away. They actually built like a little memorial for her and everything. And the joke was that she was the original CAT scan. So this is the thing with these tumors when we say negative for disease. I have to assume when I do a full body scan of you, if I don't see anything suspicious, for example, I know you're a bladder patient. I know that I got to look at your pelvic area, right? Like this is where I expect to see metastases first. This is where I expect to see anything light up and lymph nodes that maybe are infected. This is where I'm going to see them. If everything suddenly looks like any other patient, my favorite phone call to get, hey, you have patient 64382 in here. I see their diagnosis code is urothelial carcinoma. I can't find anything on their scan. Fantastic. Pop the champagne. That's my favorite phone call to get. I've gotten it a handful of times. It's not often. That's my favorite phone call because that's my goal. I shouldn't be able to find it. Are there microscopic ones somewhere? Possibly. We need to hope that my treatment continues to circulate in your blood and kind of act like those scouts to make sure that it never plants itself again and that it finally one day just zeroes in and kills those last circulating tumor cells and you never have to see me again. You see me once a year for the scans, I blow a kiss at you in the elevator, and that's it. So that would be why. Those are those two big classes of why we call it, negative for disease. We would not call a tumor patient that has a solid tumor. We would not say that they are in remission because their tumors are self-proliferating. It's not that you continue to make the tumor continues to make itself. So I hope that made sense. But that is the main thing of the terminology. And mind you, we won't get mad. Like if you say, "Oh yeah, my dad's in remission from his prostate cancer," I mean, I won't get mad. Like it's. I understand. It's used a lot in media that way, that they're interchangeable. So I get it, but you just won't ever hear us twist it for that reason. Was there any other questions? Did I miss something?
I haven't seen any other questions coming through. Cool. If you've gotten yours, I think we're
good.
Yeah, unless anybody else has anything else they'd love to throw. We really appreciate everybody for being here tonight. And yes, we are working on making this a regular series. So let Kelsey or I know things you'd like us to discuss in the future, and we'll get that planned from there. Thank you guys, everybody, for being here. Thank you, Kels, most of all. Because obviously we could not have done this without you and your incredible brain and talent. Thank you.
Thank you guys. Thank you, Angie. Thank you guys for being here and for the great questions. Again, feel free to always DM me. I will always write those down. I know some of these are more private. You just don't want to necessarily be linked to the question, and I get that. So Always, always, always. And also, like, remember, you can ask me on Monopoly Go, too. Like, I'll throw that into, like, the middle of a railroad heist. Like, I don't care. Like,
That is how this all started, by the way. I started.
That is how this all started.
That is literally how this all started. We played live Monopoly Go, and we started talking about cancer, and we're like, hey, let's have a cancer geek out, and here we are. So.
Love you guys. So love hanging out with y'all. I do too. I hope this helps clear up some things, or if it, if it makes you think in the middle of the night and you wake up at 2 a.m. and you're like, I want to know this. DM me. We can have another one of these. I think we're kind of on like a monthly situation right now, but we could do this weekly.
We can. We'll figure that out as it goes, and if people have the desire, we'll definitely do that. We can pull other people in as well as needed.
Yeah. Oh, and Carissa, I'm going to reach out to you about kind of a special. We can also talk about case studies if you guys want to.
Yes.
A case study that Michelle brought up.
Yes. You're cutting out, but
So like we can also do that too. Oh, I am. I'm sorry.
No, I don't know if it's you or me, but yes, I will follow up with you on some ideas we have that are moving forward in that direction. So thank you everybody for being here tonight. Great to see you. I look forward to seeing most of you guys on Monopoly Go in the future or tomorrow. And then we'll do another one of these soon, and we will keep you all posted. Thank you, everyone.
Bye-bye.
Good night.